and RDS. Now, how frequent is intra-amniotic infection? First of all, this is, if we do amniocentesis, we know that 22% of the patients who present with premature labor and impact memories and the liver return have intra-amniotic infection. In preterm prop, at least 50%, 1 of every 2 patients when they're admitted have intra-amniotic infection. And if the patients are quiescent, but then go into labor, is 75%, at least 75%. Now, the next question then is, remember that 1 of every 3 preterm deliveries comes from a mother who had bacteria in the amniotic fluid that can be detected with cultivation or molecular methods. A minority has a fever, so the idea of this patient doesn't have an infection because she doesn't have a fever today is silly. This is not, please don't repeat that because it betrays lack of knowledge. Now, there are 2 types of inflammations. Microorganisms that grow in culture. These microorganisms have a bacterial signal that is a 16S gene, and they have an elevated concentration of IL-6. But in some cases, there is inflammation, an elevation of interleukin-6 or white blood cells in the amniotic cavity, but the bacteria is absent, and in addition, there are no bacterial signals to be detected with PCR. Now, the lower the gestational age of presentation, the greater the risk of intra-amniotic infection in red, but also sterile intra-amniotic inflammation. Sterile intra-amniotic inflammation is induced by alarmins. Those are host products that are released that can, when the cells are stressed, or they are necrotic cells, and they can stimulate inflammation. Now, does it matter if there is intra-amniotic infection? Yes, because patients are going to the liver, no matter what you do, and then the babies are going to have more complications, more admission to an ICU, morbidity, RDS, IVH, bronchopulmonary dysplasia, and also other complications. What are the organisms? I know that you are thinking that it's GBS, but these are rarely cause of intra-amniotic infection in most cases. The most common microorganisms are illustrated in this slide. These are the different taxa. And what is important is that the overwhelming number are genital mycoplasmas, be that ureaplasma and mycoplasmas. And GBS, for example, is only present in 3 in comparison with these 57 cases. Genital mycoplasmas are bacteria without cell wall, and they are ampicillin and gentamicin, which are the antibiotics routinely used in clinical obstetrics, do not eradicate ureaplasma or mycoplasma. Now, intra-amniotic infection can lead to fetal invasion, so the bacteria from the amniotic cavity can invade the human fetus, and we know that because the Fetal Medicine Foundation did amniocentesis cordon, and they found that 30% of patients will have an amniotic fluid culture with preterm prop, and then 33% of it, meaning 10 out of 30, will have fetal bacteremia. That means that I want you to think about this, because this means that of 10 patients who have preterm prop that you admit to the hospital, 1 of every 3 or 1 of every 2 have bacteria in the amniotic fluid, but 1 of every 10 have fetal bacteremia, and those are clinically silent cases. Now, if the bacteria reach the fetus, we have a systemic inflammatory response, and this is bad because it affects multiple organs. It affects the lung, because when the fetus breathes amniotic fluid with bacteria, then that bacteria can find its way to the lung. This is pneumonitis. If the baby had survived, it would have developed consolidation of pneumonia, and the combination of bacteria, inflammation, barotrauma, and oxygen is responsible for this, which is chronic lung disease. Many babies are cripples because they have RDS or atypical RDS, and then they develop chronic lung disease. The other major complication is that systemic inflammation can cause inflammation of the brain. This is periventricular leukomalacia, and this is the major risk factor for cerebral palsy. Of babies who have cystic brain lesions, 80% develop cerebral palsy. And here is a baby with cerebral palsy. You can see that the baby has problems with posture. The reason why the legs are crossed is because the legs are paralyzed and the baby is resting in the upper extremities. Now, this occurs because the fetus develops neuroinflammation. You can see there is inflammation of the umbilical cord. The risk of cerebral palsy is greater if there is no umbilical cord. And it has nothing to do with histologic chorioamnionitis, because acute chorioamnionitis is a maternal inflammatory response. The next question is, how do we diagnose infection? Well, I already told you that most of these infections do not have a fever. So asking the patient if she has a fever or taking temperature is not going to help you. In addition, the maternal white blood cell count is not helpful. And the CRP is not sensitive either. So the only way to diagnose intramniotic infection is to do an amniocentesis. And what test do we do in amniotic fluid? The tests are the same tests that all physicians are doing in a patient that they suspect meningitis. We do a lobar puncture, we check a gram stain, amniotic fluid glucose, and then we do cultures to detect bacteria, and also we measure the white blood cell count. It's the same here. Gram stain, we do cultures for aerobic and anaerobic bacteria, but the most important cultures are genital mycoplasmas. These are cultures that are simply available. This requires nothing sophisticated. We do a glucose because if you have microorganisms, the organisms are consuming glucose, and white blood cells in amniotic fluid are consuming glucose. So, important to do an amniotic fluid white blood cell count. All laboratories in the world can do a white blood cell count, so for sure in Asia you can do it. You can do a glucose, but you need to tell laboratory you are looking for low concentration. And the most important test is either interleukin-6 or MMPA, because this is better than amniotic fluid white blood cell count, and this is the cutoff. Now these tests are available. They're available in Europe, they're available around the world, and after COVID-19, these tests are readily can be done in your hospital laboratory. Now we have developed this type of test. They are available for iron 6-2, and it's simply you put amniotic fluid here, and in 10 minutes, you can determine if there is inflammation of the amniotic cavity. This test is available in Korea from a company. They have nothing to do with the finances of this company. Now, this test has 80% sensitivity, a likelihood ratio of 18, so it's very important. It's a rapid way to diagnose intramniotic inflammation. Now, cultures take a long time to do, because cultures may take 2 or 5 days to grow microorganisms. So the cutting edge is to do a rapid diagnosis with molecular methods. PCR to detect 16S is a culture-independent method, but it also takes time to do. So I'd like to show you what Pia has done in Bangkok, that is used nanopore technologies that provide almost real-time sequence, and she has generated this beautiful video in which an amniocentesis is performed, fluid is collected. After it is collected, DNA is extracted. Then this nanopore cell allows the insertion of buffer over here and DNA extracted for amniotic fluid. This nanopore cell is connected to a laptop computer, and immediately sequencing begins, and you can identify the organism in a matter of hours or in a matter of minutes, depending upon how many organisms you have. And this is helpful because sometimes we have cases like this. This is a case from Pia, a baby with preterm prom at 30 weeks of gestation. There was no amniotic fluid to do an amniocentesis, but the baby was born with pus in the nose and in the mouth. The cultures of the amniotic cavity and of the pus of the baby were negative for bacteria. But using nanopore sequencing, In 15 minutes, it was possible to identify Prevotella. In 2 hours, the species Prevotella vivia. And in 12 hours, Pia and her colleagues were able to determine that the organism had an antimicrobial resistance gene. So this is the future of molecular diagnosis of infection. Now, in the past, we used to say that if you have intramyotic infection, you have to deliver. Okay, this is a wrong concept. There is now very compelling evidence from animal studies and from humans that you can treat intramyotic infection. And you can treat intramyotic infection traditionally with empiric antibiotics. We were guessing using ampicillin and gentamicin. But now we know that there are better antibiotic combinations and we can treat intramyotic infection in this setting. What is the evidence that we can do? We don't have a lot of time, so I'm going to show you very quickly. The first study took 20 years to do, was done at the Seoul National University under the leadership of Dr. Yu. This is a study of singleton gestations between 20 and 24 weeks of gestation. Patients presented with premature labor. Amniocentesis were done to diagnose intramyotic infection or inflammation. All patients were given who had infection or inflammation. So you need to remember that includes intramyotic sterile inflammation. Were given cephalosporin, clarithromycin, and metronidazole. The doses in the next slide. And then the patients were offered a follow-up amniocentesis. The combination of antibiotics was a cephalosporin. This dose every 24 hours. It's convenient because only one time a day. We use clarithromycin by mouth, but I hope that in your centers you have erythromycin IV, which will be more effective and rapid acting, and then metronidazole in these doses. Then we studied 30 patients who had intramyotic inflammation or infection. Of those, some had such a severe intramyotic inflammatory process that nothing is going to stop them, and 21 patients delivered. Of the 29 patients that remained, some didn't consent to repeat amniocentesis because we have to ask permission to the patients, but 18 had repeat amniocentesis. And of those, 16 cases had resolution. Instead of having inflammation in red or bacteria, these patients have resolution the infection or the inflammation. And this resolution occurred in 84% of the cases, 16 or 19, but you can do the numbers in a different way. The only important concept is that a subset of patients who don't have a severe intramyotic inflammatory response that we want to deliver are amenable to treatment. This has been done in monkeys. Aureoplasma has been placed in the amniotic cavity, bacteria. The monkey has been treated with antibiotics, and this has eradicated the infection, the inflammation, and the patients have delivered later. Also with beneficial effects for the fetus. We have done it in rabbits, the same story. This is also the case for cervical insufficiency, and is also the case for preterm trauma. And we have done these studies by diagnosing intramyotic infection or inflammation, which has a terrible prognosis because these patients go on to deliver. We have proven that antibiotics can erase intramyotic infection and sterile intramyotic inflammation. And not only, and these antibiotics are antimicrobial, but it's important to remember that clarithromycin has anti-inflammatory properties by interfering with NF-kappa B and the signals of inflammation. So here is the evidence for cervical insufficiency with success in 59% of the cases overall. What are the conclusions of what I have told you? First, intramyotic infection is present in 1/3 of all preterm birth and is clinically silent. So forget this fever and white blood cell count of the mother. Second, it is a risk factor for adverse maternal, fetal, and neonatal outcome. Third, the diagnosis can be made, but it requires amniocentesis. And if you don't want to do amniocentesis, you need to think about doing oncology, reproductive endocrinology, or urogynecology. Those are excellent disciplines, But in order to know what is happening in the amniotic cavity, you cannot do that by any other means today. Perhaps 20 years from now, we will have non-invasive ways to do it, but those ways are not available today, and the patients that you're seeing have intramyotic infection. They have a bad prognosis, and more importantly, those infections can be treated. Imagine if you were to be in a situation where your patient were to know that we know that if a patient has preterm labor, preterm problem, cervical insufficiency, they have a very high rate of infection. We know that you can diagnose those infections and you can treat them. And sometimes these patients, they don't go on to the liver and they develop cerebral palsy. Some of those patients who develop cerebral palsy, a substantial number, is because they had neuroinflammation. And imagine if they were to find out that those infections could be diagnosed, could be treated, and we elected not to do that. Our therapeutic frontier is immunomodulation. We have recently demonstrated that you can block a cytokine storm in the fetus in utero, and this is associated with a lower rate of preterm delivery, a lower rate of neonatal morbidity and mortality, and also neurodevelopmental issues. We have done this in animals, and the frontier is to do this in obstetrics and neonatology. Thank you very much for your attention.